Welcome all the participants to this webinar series of GIC 2020. Today we have two topics and we have two excellent speakers. The first topic is about the use of technology in the management of diabetes, which will be taken by none other than Dr. Banshi Saboo. Everyone is familiar to him. He is a chief diabetologist and chairman at the Diabetes Care and Hormone Clinic at Ahmedabad, is president of RSSDI for 2019 and 2020. He has multiple publications, had very good work in RSSDI guidelines and management of diabetes. Also CGM guidelines, national and international guidelines. He is a part, and it is honor to be the audience in that talk. The another speaker is Dr. Sanjeev Phatak. He will be talking about Blue Index. Also, he has many publications in various national and the international journals. He is founder at Vijayanta Diabetes Center. He's speaker at various national and international levels. Is principal investigator in many key diabetes mellitus clinical trials and contributed immensely in the various research and the scientific papers and publications. I welcome all the attendees, as well as I welcome all the speakers to start the program. Welcome, sir.
What I'm going to talk in next 10 minutes about the new technology in diabetes management, that's CGM and AGP. I don't have any conflict for this talk. I'll be talking about introduction, challenges, type A1C, beyond A1C, we are moving beyond A1C, that is CGM and time in range. We will be talking something about the clinical cases, and then I will conclude. The biggest challenge in diabetes care today is 70% of our diabetic patients have uncontrolled diabetes. The worst part is many of them, they don't know that their diabetes is uncontrolled. It leads to more complication. Poor monitoring is the main reason, I think, which is the biggest problem. Many of our patients are not monitoring at all. And technology used in our country is really very low, particularly in our country when it comes to health or diabetes. A1C is the gold standard. All of us, we know from our DCCT trial as well as UKPDS that whether you see at any point, the tighter the glycemic control, you have less and less complication, which is more with microvascular complication. But even with the macrovascular complication, it is less if you have a tighter glycemic control. But HbA1c is not always a reliable marker of a glucose control. Even an intensive lowering of HbA1c level alone, without keeping blood glucose variation in check, typically results in an increased incidence of hypoglycemia. Glycemic variability, considered a major cause for micro and macrovascular complication. CGM, it's a continuous glucose monitoring, which provides better insight into a real-time glucose trends, which offers a better therapeutic approach. The risk of hypoglycemia, if you see this DCT trial, you will see that those patients who could achieve their tight glycemic control less than 7, they were getting almost 60 to 80% of the time a severe hypoglycemia in a year time. So why we should do a CGM? If you have a patient of type 1 who is typically monitoring his sugar before meals, that is before breakfast, before lunch, before dinner, and before even at bedtime also, still you may miss some of the peak or some of the hypoglycemia. Even most of the time self-monitoring of blood glucose may come normal. I mean, before in the range of 80 to 120. Even you may have two different type of the patient with the same HbA1c with almost like 8.5 or 9. The two same type of patients, but one may have higher glycemic variability while other may have lower glycemic variability. So we need to go beyond A1C. It's not just A1C. We have to think time in range. It means glucose in range most of the time, the frequency, duration, and severity of hyperglycemia, frequency, duration, and severity of hypoglycemia, and overall glycemic variability. And these are the short-term patient-centric metrics, but they can be obtained only through continuous glucose monitoring. So the time in range is a concept which means the at how much time patient remains in a glucose range between 70 to 180, and that's what the standard range is. The new metrics of glucose control, which is time in range, if you have a time in hypoglycemia which is below 70, 70 to 180 is a time in range, and time in hyperglycemia when it is more than 180, or if it is more than 250, we call it level 2. What's the difference between A1C and time in range? A1C, it evaluates single A1C level, while time in range, which we can obtain through continuous glucose monitoring, it evaluates continuous glucose level. And that's the biggest difference, because one thing is showing you like a video, you know everything and you know all the fluctuation also. Does time in range lead to long-term complication? Yes, we have data to support that. The person who are more in time in range have less complication in compared to the patients who are not in time in range. One of the guideline which was for the continuous glucose monitoring, which was along with ATTD, a conference in 2017. I was one of the experts from all over the world, and from Asia, I was the only one in this consensus which we made international consensus on use of continuous glucose monitoring. And the same was adopted by American Diabetic Association in 2019. The same consensus, it was adopted in ADA 2019 guideline also. The targets in adults with type 1 diabetes and type 2 diabetes, it is very simple. 70% of the time they should be in time in range, which is 70 to 180. They may be 4% of the time less than 70, or more than 180, but less than 250, or more than 54. That is 4%, 25%, and less than 1% of the time severe hypoglycemia or severe hyperglycemia. Let me explain you this time in range with some cases, that how it educate the patient. A type 2 diabetic patient who is on dual therapy with a slightly uncontrolled diabetes, diet is uncontrolled, patient is not ready to understand how a small amount of sweet increases his sugar level. And what we have done, we have just put the patients on a continuous glucose monitoring, and you can see in this patient, after 4 days, the patient sugar was getting, post meal sugar was high, and we explained the patient even a small amount of sweet which he is taking along with his meal, how it increases the sugar level. And by explaining and by understanding that situation, you can say in last 6 days patient sugar is absolutely normal. So I mean, it is just an education or the behavioral which we changed after doing a continuous glucose monitoring for this patient. No medication is changed, and patient sugar is absolutely well controlled. So a patient who was having post breakfast sugar of almost 250 or 300 with a HbA1c of level of almost 8.2, this patient we could achieve a target with the patient on a 13th or 14th day. You can see the patient is absolutely well controlled without changing any therapy. The other guy who is a 58-year-old type 2 diabetes, 10 years of diabetes, uncontrolled with A1C of 9.3. And all patients, I mean with the patients of 9.3, everybody advised the insulin. Patient was not ready. We explained the patient that not only I want to put you on insulin, but I want to put you on a GLP-1 analog also. And because the diet habit, what we have asked for the patient, and we could see this was the first 6 days of a continuous glucose monitoring. Every time sugar was more than 300, 250. What I have done for this patient, we have put the patient on a once in a week GLP-1 analog along with basal insulin. You can see on 5th day, from day 1 to 5th day, its fasting sugar had control. Like anything, its fasting is around 90, and the post meal sugar, which is post breakfast, post lunch, post dinner, had come down to almost 180. On the 6th day, it had come absolutely well controlled, and this is the next 6 days. So patient was put on a basal insulin along with GLP-1 with a HbA1c level of 9.3. We had put on a single shot of a basal insulin and once in a week GLP-1 analog, and we rather reduce the dose of sulfonylurea for this patient, and patient had not gone a single time in hypoglycemia, and HbA1c is well controlled. The other guy, uncontrolled diabetic patient with A1C of 8.8. A patient is already on triple drug therapy. Again, a right candidate to start with the patient on insulin therapy. Patient was reluctant, and I was also, because the diet which we have asked for that patient all the time, it was the post meal sugar which was very high. And after explaining the patient, we added two things. One is SGLT2 and other is AGA. Now, I mean, there is no guideline which shows that after a triple drug therapy with a HbA1c of more than 8.5, a right candidate to start with only insulin therapy only. And this particular patient, I just added SGLT2 and we added alpha glucosidase inhibitor. And you can see after the 6th day, the patient sugar started becoming normal. Rather, I reduced the dose of glimepiride. We put the patient on a single 1 milligram daily dose, one before dinner only, with metformin 2 gram, with SGLT2, and with AGA also. And you can see the last 5 days, sugar is absolutely well controlled with a patient of 8.8 HbA1c. The one last case which I want to talk about, the pregnant female, a GDM patient. The patient was not ready on insulin. As we know that GDM guideline, DIPSI guideline, if post-meal sugar is not getting control more than 130, definitely patient has to be on insulin. But we are forgetting that 50% of our patients of a GDM also can be controlled with good diet control also. And this what we have done for these patients. We are not used in this patient insulin therapy. The post-meal sugar was very high, and we just control the patients only on metformin, which can be given, and along with that, patient was only on diet therapy, and patient sugar was well controlled. Yes, we never told that you will not require insulin therapy. Maybe in third trimester you may require insulin therapy, but at this point of time, patient insulin was not given. So the idea is that now we are moving from glycemic triad to glycemic pentad. It's not just the fasting plasma glucose, post meal glucose level, or HbA1c. We are more worried of, or equally worried for, glycemic variability, and more than that, we are worried for quality of life. What Vivek was just talking about, treating a diabetic patient in an elderly. I mean, every time HbA1c may not be the less than 8 is required. Sometimes you may achieve less than 6.5 or 7 in elderly population also, if you don't get a hypoglycemia. So the idea is one should not get hypoglycemia, and one should have a good quality of life, and that is what we are moving from glycemic triad to pentad. I have done one paper with the use of ambulatory glucose profile for improving monitoring and management of type 2 diabetes. This publication which we have done in JAPI, where we had shown that how AGP is effective not only for monitoring but for managing type 2 diabetes patients also. I have done also consensus for continuous glucose monitoring in India, that what should be the recommendation. And we have also come out with a paper which is outcome of AGP in uncontrolled diabetes. And you will be surprised that 90% of the patients, they will ask for that they want willingness to repeat the AGP also. So I mean, that's 90% of your patients may say they want again to do it. Uncontrolled diabetes is a major problem, and most of the time, to educate and to motivate the patients, we require a monitoring tool. And I think one of the best monitoring tool which we have is a continuous glucose monitoring or ambulatory glucose profile. With this, I thanks once again, thanks to GIC organizing committee, and thank you very much.
Good afternoon, and thank you, Vivek, and thank you, chairpersons. And once again, thank you very much, the Joint International Conference, the SIMS team, for inviting me again and again for your wonderful meeting every year. I'll be talking about the integrated diabetes management. And for that, we have designed, myself, Dr. Banshi, Dr. Padmanabh is here, Dr. Dharmendra Panchal, Dr. Shivangi, who is in UK now, and many of our team members, including Dr. Manoj Vitlani, Dr. Jetfani is here. We have also published this in one of the international journals and in the international conferences also. What does Blue Index mean? And then I'll come to the case. It's a term that has been coined to represent the overall health of the patient with type 2 diabetes, not only glucose control. All the ways in type 2 diabetes management, 80% of the times we discuss about the glucose control, that which drug is better with metformin, whether it is SGLT2, whether it is DPP4, whether it is sulfonylurea. But actually, their role is just about 20 to 30% in reducing the complications of diabetes. It is not just A, that is A1C control, but we know that B, that is blood pressure control, and C, that is cholesterol modification, plays extremely important role in preventing or even preventing the further progression of the complications of type 2 diabetes. So ABC is always there. But in addition to that, if that is not taken care of by the DEF, that is diet, exercise, and regular follow-up, regular monitoring by the patient, the purpose gets defeated. Moreover, in our diabetic patient, in addition to the DEF, the G, that is general health, also plays a very important role. So though their blood sugar may be normal, their blood pressure may be normal, their lipids may be normal, but if their general health is not normal, then there's no fun in living. At the same time, habit prevention or abstinence from the habit is also an extremely important step in preventing long-term micro as well as macrovascular complications of diabetes. And finally, I, that is infection prevention, because not all patients of diabetes die due to cardiovascular disease, though all the bombardment all these days, all these years has been to prevent cardiovascular disease. No doubt they are extremely important, but a lot of our patients also die due to infection. So infection prevention is also an important goal in diabetes patients. Based upon all this, we have developed this tool, which consists of two parts: the diabetic health score and the complication score. The health score consists of 10 parameters. We'll just go to that. And the complications part takes care of the macrovascular, microvascular, and food complications. And we express the blue index as, we express the blue index as DHS, that is diabetic health score slash complication score. It's not a division, it's not a ratio. It is expressed just like blood pressure of 120/80. It's just like that, DHS slash complication score. Higher the DHS, that is higher the health score, better it is for the patient. Lower the complication score, better is it for the patient. The choice of the name blue is inspired by the color of the IDF, that is blue logo, Unite for Diabetes. As discussed, there are 10 parameters. A is A1C, that means glucose control. B is blood pressure. C is cholesterol. D is diet. E is exercise. F is for follow-up. G is for general health. H is for habit prevention. I is for infection prevention. And J, that is jeopardy of diabetes management. Because all the medicines which we give, whether it is an SGLT2 inhibitor or metformin or sulfonylurea, whatever medicine we give, or maybe statin, they are not devoid of side effects. And that's why educating our patients regarding important side effects is also an important thing to do in type 2 diabetic patient, because unless you have educated your patient about the side effects, the overall adherence as well as the compliance rate of the patient will be low, leading to a poor outcome. This is followed by K, that is the complication score. We'll just come to one by one. A, that is average blood glucose. In this, we have included 3 parameters which are extremely important. That is A1C, fasting, and postprandial. And whenever indicated, need for self-monitoring of blood glucose or ambulatory glucose profile, which we often do, not in all patients, but whenever indicated. And based upon the A1C, closer to the target they are, higher the score they will get. I'll not go into details of this because of the want of time. B is for blood pressure. A normotensive patient without any antihypertensive gets full marks, whereas a person with higher blood pressure, in spite of medications, obviously will get lower marks. All this is based on the ADA as well as some of the Indian guidelines, and the scoring has been developed based upon that. C is for cholesterol, and cholesterol for our patients include LDL target of less than 70, because in diabetic these are high risk patients or extremely high risk patients. So LDL target of at least below 70, non-HDL of below 100, and triglyceride of less than 150. If everything has a target without medicine, patient gets full marks. Otherwise, he will get less and less. In diet, again, 3 components are important: calories, composition, and meal pattern. If everything is okay, if patient is fully compliant, full marks; not compliant, less marks. Exercise, again, aerobic activity, then a work-related activity, and muscle strengthening exercise. All these are given extreme importance, and based upon that, the marking or the scoring is done. Follow-up. The follow-up does not include just follow-up at the clinic, but follow-up as far as the self-monitoring whenever indicated, follow-up regarding the lab or the other evaluation periodically that which are needed, like HbA1c, yearly renal function, yearly lipid profile, foot examination, retina examination. And follow-up also includes medication adherence. And you might be aware that most of the complications in diabetes just do not result from poor prescription, but they result from poor medication adherence. Poorer the adherence, more are the chances that the patient's blood pressure, lipids, and blood sugars may not be at control and leading to long-term complications. G is for general health, where we have now not 8 but 7 parameters. We have excluded malignancy in our latest update. Obesity, sleep apnea, anemia, thyroid disease if not controlled, bone health, mental health, because diabetes is associated with depression, anxiety, And there is a syndrome called diabetic distress also, diabetes itself giving rise to distress. Liver dysfunction, because most of our patients are having fatty liver, and these days we see more and more fatty liver disease progressing into chronic liver disease leading to cirrhosis. So all these are also taken into account when considering the general health. The habit prevention, especially smoking as well as tobacco, and when alcohol is as a habit, also that plays an important role in this scoring system. As I earlier told that in our patients, not only cardiovascular or microvascular complications are important. Many of our patients die due to pneumonia. Many develop urosepsis. These days, genital infections are also becoming very common in the era of the SGLT2 inhibitors. And that is why infection prevention is also a very important parameter which we must look upon whenever we take care of a diabetic patient. In infection prevention, 2 vaccines have been recommended very strongly for our diabetic patients, that is influenza vaccine annually as well as pneumonia vaccine once in 3 years or based upon the high risk, and hepatitis B vaccine. Finally, the jeopardy of diabetes management, that is the side effect of whichever drug which we are giving, especially hypoglycemia with insulin or sulfonylureas, genital infection with SGLT2, weight gain with pioglitazone, antihypertensive causing some side effects. So all this must be explained to the patient whenever it is possible. Based upon that, we calculate the score, and let me be very frank with you, with the educated staff and motivated patient, it takes hardly 5 minutes. First time it takes just 7 or 8 minutes. In the follow-up, it takes less than 5 minutes. Thereafter comes the macrovascular score, that is cardiovascular score. Higher the complications, more will be the score. And here we want that patient should have less score. Followed by renoretinal score, that is retinal problems are there or there, renal problems are there or not. And finally, foot. And foot we have taken as a separate entity or a separate complication, because foot is a combination of micro, macro, bone, joint, skin, infection, all together. So you cannot define foot as a micro only or macrovascular complication only. And that's why we have treated foot as a different parameter altogether. What is the strength of this tool? It's a continuous patient education and motivation. It's a holistic evaluation of the disease status, not just glucose control, but his vasculometabolic WHO definition of health, biopsychological model of health, and it is a patient-centered approach. By way of this, we have already published it in Diabetes Care and last year in IDF also. I'll just give you example of this case. A female, initials GRT, age 49, height 152, BMI is 28. We assess the parameters at visit 1, and the score was 30. With motivation, by explaining this, her score improved to 41 in 3 months. The message is not that by improving the score you will be able to reduce the complication, but the quality of life, the patient motivation definitely will improve. We now have more than 2,000 patient data for last 2 years. Whether it will translate into reduction in complications or not, only time will tell. With that, I would like to thank the audience again very much for your very patient audience. Thank you again.
Hello.
Good evening, sir.
Yes, good evening.
Good evening, sir. There are many questions.
Yes.
Sir, there are many questions from the audience. If
Hmm.
either Bansi sir or you can take that one of the questions. So one is a question from Dr. Pramod Pradhan. Is that in CKD, which anti-diabetic drugs are good?
Bansi.
So, yes, any one of us can take. It's really pleasure to see all of you. And since long, actually, I could not meet Dr. Sanjeev Phatak. So really missing him. But every alternate day, I'm able to see him. Belated happy birthday to Dr. Sanjeev. And CKD management, the best is when you have the creatine or when the EGFR goes less than 15, you know that it's only the insulin therapy. But the point is when we have EGFR is less than 90, what we should use. When it is less than 60, what we should use. When EGFR goes less than 45, when it goes less than 30, and then when it goes less than 50. I mean, in a different EGFR value, accordingly, we have to decide the dose. But one thing is very clear with the patient with diabetes, with renal dysfunction, and now even with non-diabetes CKD after the DAPA CKD, probably the SGLT2 will be a choice of therapy. At present, with the DCGI regulation, the SGLT2 you can initiate the therapy till you have EGFR up to 45, but it should be stopped when EGFR goes up to 30. But off label and across the world, now we started using EGFR when even if it is below 45 to initiate the therapy, and we continue the therapy till EGFR is up to 20, or even some of the data had shown that even if it goes below 20, the SGLT2 can be used. The efficacy wise, the glycemic efficacy of SGLT2 will definitely be reduced once the EGFR goes down. But the benefit of SGLT2 is just not for the purpose of glycemic efficacy, for the purpose of further progression of CKD that get decreased or reduced by using the SGLT2. The GLP-1 is the second good choice of the drug which should be used in the patient with the CKD also, but we don't use it. One of the reason is it also causes nausea and fullness, and some of the time the patient with uremia or patient with a decreased renal function may have the similar type of symptom. So that's also one of the reasons we are not using, and the second is the cost and the other thing. Sulfonylurea we can use. Definitely the short-acting sulfonylurea are choice in compared to the longer-acting. The gliclazide is found to be less hypoglycemic. There is data in the CKD, but same we are finding with glimepiride, and we do use glipizide too. The dose is to be reduced. The metformin, again, with the less than 45 EGFR, we should be bit cautious to decrease the dose. But definitely those with EGFR less than 30 at present contraindicated, but we do use as off-label, but in very low dose when we find that it's very highly insulin resistant and we can't get without using metformin, but it's very, very low dose and we have to be very cautious also. Regarding glitazone, you can do use, but again, the problem is that it leads to fluid retention. That's a problem with the glitazone. So that's the reason that glitazone also we don't use very often. Alpha glucosidase inhibitor we can use up to the EGFR of 30, but again, we use it even below 30 EGFR in many of our patients, but you have to be a bit cautious when the EGFR goes less than that. The AGI, the glucose and voglibose, both molecules are there. So then otherwise remain is the insulin, which is the safest, and basal bolus therapy is good in compared to the premix insulin, because the longer acting insulin require less dose, because otherwise it may lead to hypoglycemia. I'm sorry if the answer is long enough. I mean too long.
Excellent, sir. You have covered all the medication issues in the CKD patients. Another question is that what are the early diagnostic parameter for diabetes and how we can manage the very early stage of diabetes? I think the attendees want to know after listening the talk of using of CGM in a management part. Is there any role of using this CGM in a very early stage of diabetes to detect in a very early stage of diabetic patient even before their HbA1c starts rising?
So, to be very frank, it is officially not recommended by any guidelines to be used for the continuous glucose monitoring in the patients who are pre-diabetic or who are even pre-diabetic. So somebody wanted to know who is at the high risk of developing diabetes. But there are data to support that even the 1 hour sugar post meal sugar is higher, and they are the one who are going to become more diabetic in compared to the event. So that's the earliest manifestation of a uncontrolled, a earliest manifestation of pre-diabetic population also. Sometimes to educate, to motivate, to change the dietary pattern, to change the lifestyle, we do use the CGM in pre-diabetic population or the person. Like today, I had put one patient who is on 6.4 HbA1c, and we just wanted the person does not want to take any other therapy, and he's very keen that lifestyle modification he will definitely change it, and we will able to get his HbA1c. So I mean, such type of patients are there where you can motivate them, you can educate them, and you can prevent them by using this type of monitoring technology, which will help them to detect the earliest post meal glucose pattern, and where you can change their diet, you can change their carbohydrate content, you can increase the fiber content, you can increase the complex carbohydrate, and you can decrease the weight of the patient. So, I mean, by all these means, yes, it can be used, and we are using it also, but it is not by the level of at the guideline level. So the ACE or EDA or RSSDA or any international guideline, including the even ATTD guideline, is not telling that it should be used for that. But at an individual choice, when we are discussing with the patients, if both of us are agreeable, I mean, we agree for many times, and we can start using CGM for these patients also.
Excellent, sir. Sanjeev, sir, there is one question regarding how effective can be the non-pharmacological approaches in a management of diabetes.
Well, it can be extremely helpful. Actually, you are aware about the Roy Taylor's direct trial, where he stopped anti-diabetic even after 2, 3, 5 years of diabetes, and he could achieve remission in about 86% of the patients if they lost 15 kg. So non-pharmacological therapy is extremely effective. Whatever pharmacotherapy we have just complements the non-pharmacological therapy. So if you are giving pharmacotherapy, it does not mean that the diet and lifestyle are not important. They are extremely important at every point of time. So every time patient visits you, you must reinforce the dietary habits. You must reinforce whether patient is exercising or not, the other lifestyle factors. And you would be surprised that during this 4 or 5 months lockdown, we have seen improvement in the glycemic control of so many patients who are not getting good control just because of the improvement in the lifestyle. Their outside eating has gone down, the social functions have gone down. Some of them have realized the importance of exercise and easy life. And this is the best example. So even in absence of the direct trial replication here, we have seen the effect in this lockdown period. So diet and lifestyle are extremely important. Nothing can undermine that.
Sir, to extend the question, there is another question that is there any role of fructose in a diabetic patient? Use of fructose
Well,
in
fructose,
diabetic patient.
yes. So ultimately, fructose will get converted into glucose, and it will also get converted into triglycerides also. So in limited amount, the fructose that is there in the fruits is okay. But if you are giving it as a supplement with the view that it will help in getting the blood sugars under control and it will not increase the blood sugars, it is not true. So it will also get converted into glucose, will increase the sugar, may also have effect on the triglycerides. So in restricted quantity, that's what we allow during the in the fruit exchanges. But otherwise, taking fructose as a replacement of sugar is not advisable.
Sir, there is one
Vivek,
more
we
question.
can also have your quick comment from you.
Yes, sir. Again, sir, fructose, as you rightly said, it is going to be converted to glucose, and many of the quacks are promoting that fructose is safe and you can barely use in diabetic patient very safely. But there is a very wrong message, and every diabetic should be aware that fructose is also going to harm, and it has its own side effects.
True.
So there is one more question. So what are the precautions we need to take when we are dealing with a diabetic patient with cardiac condition? Though there is no mention that whether which type of cardiac condition, whether it is coronaries or the heart failure, but there is a general question regarding the uh, 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 diabetic management in a patient with a cardiac condition.
So we can take it as diabetes with atherosclerotic vascular disease, ASCV, right?
Yes, sir.
Now, in addition to diet and exercise, in such patients, whenever it is possible, we must use an SGLT2 inhibitor with established cardiovascular benefit, or a GLP-1 analog, or both if it's permissible, along with metformin. Of course, metformin will remain the backbone, but along with that, SGLT2, regardless of HbA1c, we should use, and the one with highest cardiovascular benefit, obviously. The drugs which we should avoid if patient is having heart failure is sexagliptin, pioglitazone. These two drugs should be avoided. Hypoglycemia must be avoided in such situations. So that's why DPP4 inhibitors, though they are not having any cardiovascular advantageous trial, but they are cardiovascular neutral and do not cause hypoglycemia. That's why they have a preference over sulfonylureas in most of the circumstances. Again, AGIs are good drugs for these patients if they have postprandial hyperglycemia. Having said that, if patient's LV is good, if he does not have edema or diastolic dysfunction, pioglitazone is also having good cardiovascular outcome trial in the form of proactive. So in absence of contraindication, pioglitazone can also be used and may provide some benefit in the atherosclerotic vascular disease. So these drugs will have preference compared to the other drugs.
Uh, there is one more question, sir, and I would like to comment from both our experts that what is your take on early initiation of SGLT2 inhibitor and DPP4 inhibitor combination in a diabetes even before metformin, to avoid the long-term complications of cardiac as well as the renal complication.
So Vivek, one thing is not from both the experts. We all three would like to answer for the same. That's number one.
Sure, sir, sure.
And number one is regarding the combination of both the molecules to start before metformin. Actually speaking, I am not very much for it. As far as SGLT2 inhibitor is concerned, yes, it can be used as a first choice of therapy before metformin if the patient is a drug naive or who is presented with cardiovascular disease. So, I mean, a patient who is straightway either had gone to a cardiologist and that time only detected with the diabetes, even the sugar may be 7 or 7.5, not very high. So the first choice of therapy, if I have to use only one drug for this patient, I would like to use SGLT2 instead of putting the patients on a metformin and SGLT2. That's the only advantage, and that's what the different guidelines also are talking, and the European Society of Cardiology had endorsed it. And after the DAPA heart failure paper, which was just published in ADA, we all endorse that, yes, with the patient with established cardiovascular disease, that should be the choice of therapy. The DPP4 before metformin for a long-term complication, at present, we don't have any data to support it. So I will not support that combination of these two can be before it. But yes, we do use DPP4 before metformin in the patients with the elderly population or the person who is contraindicated with metformin, or the patient who is not tolerating the metformin. So like a person with a CKD, my choice of oral anti-diabetic agent will be the DPP4. Or the person who is not tolerating the metformin, even I may start before using the metformin, even a DPP4 agent also. But these two combination, will it replace just metformin before that? At present, we don't have the data, but for SGLT2, definitely before metformin I can use. But if patient is not drug naive, he's already on some drug and he's already on metformin, then I will add metformin plus SGLT2. I will not remove a metformin with a patient who has established cardiovascular disease. So these two molecules will be started with that. If I have to use two drugs to be added because the sugar level is more than 1.5% of above the target level of that particular patient, then I may add two molecules simultaneously along with metformin, and that is what we are doing for many of our patients. But I would like to listen from Vivek, you as well as Sanjeev Phatak.
Yes, I agree with you, Banshi, that especially except for the special circumstances, like you mentioned, if patient is not tolerating metformin or metformin is contraindicated due to some reason, then we use some other molecule ahead of metformin. Otherwise, we use something with metformin. We never use metformin alone these days, except when for prevention of diabetes. Once HbA1c is more than 6.5, I think every one of us, I believe, should use combination. and this combination should be with metformin. Maybe a fixed drug combination or separate, that is your choice. We must not forget that diabetes just does not result from insulin resistance. So metformin is the drug for insulin resistance. But along with that, beta cell defect is also very, very predominant in type 2 diabetic patients once the diagnosis is there. So we must address the beta cell also. And to address that, the safest molecules right now are DPP4 inhibitor. In addition to that, as Bansi rightly pointed out, that if patient is having established cardiovascular disease or at risk of heart failure or is overweight, we can also start him simultaneously on an SGLT2 inhibitor. So I may not be surprised that the future guidelines will tell you to start with metformin, DPP4, and SGLT2, all three together, because none of this, even when used in combination, are going to cause hypoglycemia. So these days may not be far from today.
Vivek,
I,
excuse me. I'm just sorry for this.
Yes.
I have to join one more meeting. I'm sorry, I'm leaving this, and you please continue the discussion. I'm sorry.
Yes. Bansi.
sir, sir,
Okay.
thank you, sir.
And
Thank you,
belated
sir, for
birthday
joining.
wishes to you also.
Thank you, sir.
Yes, sir, very
You
rightly
know,
said, sir. It is always the combination of metformin with other molecule, because right now we are not using metformin monotherapy in majority of our cases, and it is always that what we are using, what we are going to use along with metformin, and even the guidelines which suggest that the use of SGLT2 inhibitor in a patient who are drug naive as a first line of therapy. Even the second line, they suggest that start of metformin rather than going for a DPP4 inhibitor or GLP-1 alone. They suggest that if with SGLT2 monotherapy, the HbA1c is not controlled, then patient should be added with the metformin. So yes, right now still metformin remains the backbone of the diabetes management, unless there is a huge contraindication or the or another issues with the metformin. So there is one last question which with regarding to blue index specifically. Uh, in patients with high risk associated with diabetes, can blue index provide an accurate diagnosis? And how effective is the prediction of blue index in such cases? And is there any fallback of using this blue index particularly? Is there any disadvantage or any limitations of using this blue index?
Okay. It's a very good question. Yes. Hello.
Yes, sir.
Yes. My apologies. There is a disclaimer here that blue index is not for prognosis. Blue index is a motivational score by which you can engage your patient, you can improve the adherence, you can improve the overall involvement of the patient and family towards the diabetes care. And it is a means by which we can educate the patient that diabetes is just not the glucose control. You need to educate them for blood pressure control, lipid modification, diet, exercise, the importance of regular follow-up, importance of his general health. His blood sugar may be normal, his blood pressure may be normal, cholesterol may be normal, he may be taking statin, but he might have diabetic distress, he might have liver disease. Obviously, all these things have to be kept in mind. Similarly, we have been stressing about preventing infection in diabetic patients. And when we wrote this blue index 2-3 years back, we were never aware that this COVID pandemic is going to happen. So now I can realize that how true we were, because infection still plays a very important role in overall mortality and morbidity of a diabetic patient. So infection prevention by any means plays an important role. So if you do all this, patient will have higher score. And if some of the parameters are not controlled, and you can stress upon the importance of those parameters to the patient, patient will have scope of improvement. Suppose his HbA1c is not good, suppose his diet is not good, these two things are requiring focus, then you can tell the patient, counsel the patient on that, and on the next follow-up you can see the improvement. As I already told in the talk, that whether it will reduce the number of complications or not, at present we do not have data. But yes, we definitely have data that improvement in this score definitely improves the quality of life, their confidence level in the disease, and their engagement into the disease. That's what I can claim.
Excellent, sir. It is a very motivational index for the patient, because the main issue in our diabetic patient is about the adherence and continuation of the medications which all are prescribed. And this blue index can really motivate them to adhere to the lifestyle changes as well as the medications. So thank you, sir. I think all the questions are being taken care of. Thank you for joining us. I would also like to thank all the attendees for joining in the evening time. Thank you all.
Thank you, Vivek, and thank you, the organizers, Docplexus, Dr. Kritika. Thank you.
Thank you, sir. Thank you.